My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I'm also the Associate Chair for Multidisciplinary Oncology in the Department of Surgery, and I am the Director of the BPREP program. BPREP is our high-risk program for women who are concerned about their risk of developing breast cancer. When we're selecting patients for breast conservation therapy, it's very important that we take several things into account. One, we have to have a clear understanding of the extent of disease in the breast. We use our mammographic images, sometimes ultrasound, and sometimes MRI to help us truly understand the extent of disease in the breast. This needs to be complemented with our physical examination findings, all to determine whether we think that we can remove the cancer with a cosmetically acceptable outcome. The goal of breast conservation therapy is just that. It is to perform a lumpectomy, leaving the breast with a cosmetically acceptable outcome with survival equivalent to mastectomy. If the lumpectomy, which will need to be performed, or if the extent of disease in the breast is too large that we will not be able to achieve a cosmetically acceptable outcome, then it's probably better for us to discuss mastectomy with those patients. When we're looking at mammographic images in selecting patients for breast conservation therapy, we're not only looking at the size of the tumor, but we're looking for any associated calcifications associated with that cancer, because of course the tumor as well as those calcifications would need to be removed. When we're doing our clinical breast exam, we're looking at the size of the breast, and we're trying to judge what we call the ratio between the breast size and the tumor size, again, to determine if we think that we can do a cosmetically acceptable lumpectomy. In women who we do not feel we can do a cosmetically acceptable lumpectomy, then we do need to talk about mastectomy. And then we would be talking to patients about mastectomy with or without reconstruction. And these are, again, very personal preferences, personal choices. We'd like to offer our patients immediate breast reconstruction at the time of mastectomy. Many of our patients do pursue this option, but it is also perfectly fine for a woman who does not choose to pursue reconstruction. And in that case, we would just leave the chest wall flat. So when we're making decisions or when we're choosing patients for breast conservation or mastectomy, we not only think about the oncologic factors, the cosmetic outcome, but we also need to think about the patient's preferences. When we choose breast conservation, we know that there is an indication for whole breast radiotherapy to follow the lumpectomy procedure. That whole breast radiotherapy is incredibly important for reducing the risk of local recurrence. So if a patient does not live in a geographic area that it is where she's able to go for whole breast radiotherapy, then maybe that patient's preferences would lean her away from breast conservation because the radiotherapy segment would be challenging. Whole breast radiotherapy is a daily treatment. It's given once a day, Monday through Friday. And so for some older patients, that also may be challenging to come for daily treatment. So we do need to consider a patient's situation and her preferences when we're talking about the treatment options as well. But importantly, we need to ensure that patients understand that the choices for breast cancer surgery, whether it is breast conservation or mastectomy, that both are associated with excellent outcomes. The outcomes between the two procedures are the same, and that bigger surgery is not better surgery.